It was Warren Buffett who said that price is what you pay and value is what you get. But our system, at least in the United States, is confused because the people paying the price are not the one getting the value, at least with the clinical outcome. We'll talk about that in context. So just qualification that this is an American view, and the healthcare systems in Switzerland and other European may be quite different than what we are. So it may or may not be so relevant. I have conflicts here. The only conflict that really has a bearing here may be that I helped design an anchor for J&J and also work with a healthcare data analytics company named Avant-Garde Health, but neither of these are going to be really talked about here. So in 2019, when I came here, I was asked to give a similar talk about the value of rotator cuff repair, and I'm going to give an update to that. But all of these products, the idea is that these drive cost. And it's true they drive cost, but there are many other things that drive cost, including time, and it depends on the episode of care. But value is temporal. And so we'll go over the time relevance. And all these guys, and even what you've seen here, have their preference, and their decisions the consequence of their decisions are the cost of the care. And we may solve the problems quite so well. And in 2022, I did another presentation where different experts, many of them, but each of them with a different idea of what they should use and cost. So really, what I'm going to talk here now is if you're interested more in this, we had a webinar on surgeon-hospital financial relationships on the Codman Shoulder Society. And so I'm going to talk about the talk I gave there, which is surgeon-related drivers of hospital costs, and a rationale for co-management. That is, that we can deliver value to our institution, except for the culture in our institution. And you'll see what I mean in a minute. So what we looked at were what are the drivers of cost in a hospital and ASC specific to rotator cuff, and to what extent do orthopedic surgeons' decisions affect overall hospital costs, and what are the pros and cons of partnering together with your institution, assuming they were smart enough to understand the value you could deliver. Now, Peter Drucker was a famous management guru, and he said, culture eats strategy for breakfast. This simply means that where you work, the context of where you work, determines what kind of structure and financial relationships you can have to create value. But it was the gangster Al Capone who said, you're either at the table or on the menu. Most of us, where I work, are on the menu. We are not part of the decision-making. Well, value-based healthcare is very complicated. So if you look at where you fall here and you can see, your doctor and then all the other players here, this is a complicated tug of war. And so when we look at these, the patient wants a durable outcome. The doctor wants a good outcome and an income. Reduce cost and control is the government. The insurance companies want lower cost and profit. You see all the companies, the products of which we use. They have a fiduciary responsibility to deliver quality and market share and profit. That's what they do if they're if they're a publicly traded company. And then your hospital wants cost containment. That's the number one priority in the United States now, is cutting costs. So the definition of value was alluded to before. Value is really the outcome as defined by the patient, absent complications. And then the cost has been described by Porter and Herzlinger, and it must be transparent. And we have no transparency where I work, or where most of us work, to be fair. So all these dollars here determine this. Now, outcome, as you'll see in a minute, is outcome over time. What is the durability of the procedure you perform? And the denominator depends on how and what you measure. Do you do traditional cost accounting for just the implants used, or you look at time as well? And there's been 100 years of this happening now since Codman, who wrote a book on the study of hospital efficiency, all the way to Michael Porter, my mentor, who redefined healthcare. So we've been looking for the promise of value over 100 years and not really getting there yet. Larry Higgins presented some of the work we did and published in Harvard Business Review entitled How to Design a Bundle Payment Around Value, where we created a warranty on outcomes for rotator cuff repair, okay? Guaranteeing outcomes for a premium price, which seems to be logical. Well, 100 years ago, Codman, in his book, demonstrated the difference between rotator cuff repair that succeeded and that failed. And it was crystal clear that he knew value because when you operate and the surgery works, it delivers greater value than if it doesn't work. In fact, more cost when you have to redo operations. And so Einstein said, if you can't explain it simply, you don't understand it well enough. And so When we look in the literature about value, there are all these metrics that we can use, and we'll delve into those a little bit. But let me give you context. If we look at all the countries here, the per capita healthcare expense in 2011, this is the data that I have, but I'll update a little bit. You can see here, United States was not the most expensive in per capita expense. It was actually number one was Norway, and number two in red here was Switzerland. That's interesting. Well, that's no longer the case because in 2020, this almost doubled in cost, and now it's even higher. So the United States is leading on cost of care per individual. Now, this is not just orthopedics, for sure. And if you look at public and private per capita health expenditures in 2022, the United States is far and away the leader in the cost of care. And if you look down here, you see Switzerland about in the middle. If we look at our tax dollars, then at least before we had Ukraine and Russia and all the other things happening in the world, the spend on healthcare was 23% of every tax dollar, which was more than our military. That is no longer the case. Military budgets are going up, and that will be at the expense of healthcare budgets and education, probably. So I'm sure all of you wonder, what is the overall cost of orthopedic care? And this comes from Ortho World, which is a commonly used industry guide. And if we look in 2024, you'd be interested to know that in 2023, the global cost of orthopedic sales was $57 billion. That's in the world, with 3.5% per annum growth. You might wonder, well, what is orthopedics? So if we look here, the orthopedic spend, as you can see here, is broken down into joint replacement being number one. And when you look further at extremities, which is largely what we do, that's a paltry $2.7 billion. And if you look here at enabling technology, which I'll talk about, I think, tomorrow, robotics and navigation and all of this, that's just only $1.1 billion. So we're relatively small. Now, in the context, this is important. This is a graph. It's old, but it's relevant. If you look at the growth between physicians and administrators in your hospital, in the yellow is the growth of administrators, okay? In the maroon is the growth of physicians. And the percent growth in the U.S. healthcare spending per capita drives the administration that grows in our hospitals. And the expense, administrative expense, which is not frontline generating revenue at all, yet they're in control. If you look here globally, how we compare, this is another very important point, because if you look at public trust in physicians, then Switzerland is number one, and the United States now is number 24. And it has a lot to do with this economic scenario. So I'm not talking just about rotator cuff. Everything all our orthopedic surgeons do is relevant. Then you would probably also wonder what I said before about time dependency. So if we look at an outcome, the hospital and the physician in the United States are tied to a 90-day post-surgical episode of care. After that, they're off the hook. All of the durability that is achieved is captured by the patient. So if it costs more to deliver something that's more durable, it is at the expense of your hospital. Does your hospital really care about the long-term durability of something for the patient? Probably not if they have to do budgeting. It doesn't work that way. These are a few books that are relevant to these concepts, some by some of my professors at Harvard Business School, that are really worth reading to understand some of what I'm telling you here. Now, back to rotator cuff. We know for a fact that the experience begins with expertise, and so you're all here to become better at what you do, and that means less cost. It's 25 to 30% higher revision rate with individuals who have less experience to do rotator cuff repair. That's the first way to reduce cost, is have quality care by quality people. Of course, a healthcare system doesn't do that. They go to most convenient. If you look at my own institution, over the course of several years, 3,100 surgeries performed, rotator cuff surgeries. Each of these bars is an individual. Well, you know, on the left are going to be the greatest value created for the patient, and on the right, not. So why in the world would the hospital allow the ones on the right to be the ones doing surgery? It should be the ones on the left. But that's not why they're hired. And frankly, the patient also is the judging, because does the patient feel confidence in their surgeon? And, you know, that has a lot to do with how they feel, regardless of whether the tendon heals, believe it or not. So how you treat your patients has a lot to do with value they perceive. Now, what matters most to the patient? Is it the subjective value? Is it the range of motion? Is it the strength? Is it healed rotator cuff? Gerber pointed out that range of motion is not only measured differently by two people, but I will elevate my arm higher if an attractive woman asks me to do so than if it's Dr. Warner asking. Okay? So our patients define value depending what we ask them. So some of the things that are value, how fast do they go back to work? Mean time to maximum medical improvement for rotator cuff repair was 7.6 months relevant to work return, at least in this paper. How about sleep? Sleep is a major factor for rotator cuff. How fast will sleep disturbance resolve? 89% of patients have a sleep disturbance afterwards, and they measure the quality of what you do based on this. Statistically significant sleep quality improves around 3 months postoperatively for rotator cuff repair. Now, what about long-term durability of rotator cuff repair? Here are some studies demonstrating very high healing. This one here by Gerber et al. Looking at the extremely high healing rate based on the approach that was science that we showed already, that many of you are well aware of. And then Uma Srikamaran, who is too many initials after his name and works at Johns Hopkins, was a former fellow, and he wrote this article that I'm happy to send to any of you. You probably would never see because it's in Techniques of Orthopedics on policy ramifications in healthcare as it relates to rotator cuff repair. So one of the things that we wrote about in this article was critical facts, that cost calculation is complicated, that most physicians have no idea what things cost, and that arthroscopic repair costs have increased 600% in 10 years. 600%, and yet you saw that chart by Gerber showing no increased healing at all. If you look from 1996 to 2006, the ratio of rotator cuff repairs to non-surgical visits has gone in favor of rotator cuff repair. More and more surgeries are being done. If you look here at arthroscopic versus open, you can see dramatic increase in arthroscopic and dramatic increase in outpatient surgery, particularly in the United States, which reduces hospital costs. And rotator cuff repair is cost-effective if you look at quality-adjusted life years compared to other things where the threshold is 50,000. And surgery is more cost-effective than conservative treatment, by and large, if you look over the lifetime of the patient. Here's a comparison between physiotherapy and repair of small rotator cuffs, and we had already talked about in this randomized trial. This one here was not so clear, yet we presented data. This group here presented data that showed surgery was better. Here's another one here about comparing surgery with conservative management. No significant difference in functional outcome at 1 year, but significant in pain relief. So it depends what you're measuring for the patient. Another one here on societal and economic value of rotator cuff repair with the authors. You can notice here Jerry Williams was part of this. The estimated lifetime societal savings, if you look at people returning to work and such and being productive, for 250,000 rotator cuff repairs performed in the U.S. each year was estimated to be $3.4 billion in savings if they were, compared to not being able to return to their work. Now, if you look at adoption of new technology, all this new technology being shown here, where will it be adopted? And it's crystal clear where I work that private groups are more likely to adopt innovation than our academic medical centers. The worst place to start with an innovation is an academic medical center because they are risk averse and they wait for demonstration of value before they will bring it into their institution. And if you look at different programs, look at all these different places in the United States, each of them has a different model. Straight salary, fee-for-service, RVU, hybrid ownership, private groups, etc. All of this depends on adoption of technology and cost control. So it's not the same everywhere. And academic medical centers, this article, which none of you will read because it's in Health Affairs Scholarship journal, basically academic medical centers excel in many ways but struggle to succeed in delivering cost-effective care in a value-based model. And much of their underperformance is due to two core competencies they lack. Number one, limited ability to redesign clinical workflows. They're rigid. And number two, an unwillingness or inability to change their relationship with us. We are on the menu. We are not at the table. We are not partners. And there are a number of other factors here I won't go into. So cost and profitability of rotator cuff repair, this particular study, overall findings showed that improvement in profitability of arthroscopic rotator cuff repair for hospital systems is possible if you change culture and you change structure. So I'm going to finish with this. This was a study we did looking at the cost of care over a large number of patients with, I think, 13 different physicians. I think we had 700 patients. And we used the time-determined activity-based accounting methodology. We found that the cost for rotator cuff repair varied by 6x among surgeons, from least to most expensive. The major cost drivers, the intraoperative costs were 91% of the cost overall of the day of surgery. The major drivers were biological adjuncts, grafts, etc., and surgeon preference for what they would use, simply preference. The additional cost drivers of tendon retraction, fatty atrophy, number of anchors used were somewhat important, but not as much. and not associated with patient age, comorbidities, or the number of tendons torn. Now, this reflects the variability of rotator cuff repair, that we are not doing just one thing, yet the insurance companies view this as one thing. Massive rotator cuff tears are the same as small rotator cuff tears to the insurance companies. And this is a big problem. So this target you see here has, in the inner circle, normalized cost per patient for the things that we do. The outer circle are the more complex things, but we're not compensated effectively for those. Neither is the hospital. So this raises many key questions in terms of what we're doing and how we should approach this and how we could help our hospitals. At my hospital, 1 month of surgery at the Mass General, 26% of all of the procedures done in the hospital were orthopedics. We are a major driver of their profitability. Interestingly, in an academic medical center, you see here, the revenue that we produce for ourselves is a shortfall of our operating costs. Our operating expenses, our costs. However, we generate 5 times as much for the hospital. So it's not an equal partnership, if you will. One more just view here, another study we did, looking, each of these is a surgeon. So in green is the least expensive surgery, and yellow the most expensive surgeons. Here it was 7x variation for arthroscopic rotator cuff repair. And all of the metrics for performance differ depending where you're doing the surgery. So for our outpatient surgery center, we're more time efficient, we're thus less costly than doing it in the main hospital. So where you do your surgery is also important. So to conclude, at the end of the day, this is a question of behavioral economics. Do you motivate, or are you motivated by a carrot or a stick? Is the reward for what you deliver in improving outcomes and reducing costs or not? And that is the crux of the problem. And if it's not a problem yet in Europe, it probably will follow what happens in the United States. And for us, we are all being driven by the stick, not the carrot. Thank you.